the flashpoint is the 30 young people throwing rocks. You can hear them impacting against them.
The scene has really gone crazy out here right now.
That's wrong. If that was my brother or my father or anybody, I would be furious. And I guarantee you, if I called his family right now and told them what happened, they would be furious too.
I flipped. We were all crying. There's a lot of nurses that know that this is wrong, but they're afraid to like say anything publicly.
She said, when I was talking to her, she said, we're not always given the orders. It comes from the top down. And I was thinking, that's not the exact problem with everything. Where's it coming from? What's the purpose? Are you guys really trying to kill everybody like everybody thinks?
Within our unit, it was a big fight, and ultimately the kid died with us over his body arguing about this.
The girl's over there.
Yeah.
And the doctors, he's like, the doctor will just write it up that we
Yeah, I don't trust him though, because I don't know him.
I'm sorry, I'm not doing that.
There's a doctor that came upstairs that I had worked with prior. He was working in the ED and heard what happened. He came into the room with me and told me that what I did was good. And then, so there are good doctors in here. I guess the word traveled after this.
You mentioned earlier that this is a common occurrence where people come in able to speak and they just have low oxygen levels and they're put on a vent. So what's going on there?
I don't know. I honestly have no idea how. They're assuming everybody is just the same. There's no individuality anymore. These residents, I think a lot of them are just stone cold. There's no emotion, and they don't view people as people anymore. And it's really sad. Like I came a little bit later, after the big rush, but there was still a lot of people coming in, and a lot of us were just in shock. Within the first couple days, you could see exactly what was going on.
My bigger problem with this whole scenario is when they intubate people who don't need it.
Yeah.
And it looks very clear to me that they're just pushing it.
You almost feel like you are literally living in the Twilight Zone, and you feel like you're the only sane one in a bunch of insane people. And it's scary because these are the people that others are trusting to take care of them, and they're really doing the opposite. I'm to the point where I'm afraid that I'm going to start thinking that this is normal. I don't want to ever get to that point because they think that, like the people I work with that are local nurses and doctors don't see anything wrong with this.
Really? I mean, they don't.
No.
Do they see? Was it just like kind of a hard past few months? Is it or?
This has been like this, and from what I hear, I mean, there are good nurses that work there too. Like I have made good friends with a lot of the nurses that do work there. There's good people, but they're outnumbered.
So what happens? People come in like this 37-year-old, and what was he complaining of, or what was going on?
Respiratory distress. He didn't have COVID either. He did not have COVID.
And how do we know that?
I took care of him. I have the same type of results from his chart as I do with my other patient.
It was like the day before intubation, he was fine on the rebreather.
And then they intubated, and then he got a pneumo, and then they put in a chest tube, and then it's been shipped.
And now he's 37 years old and dead.
Because that's what I'm seeing, like all these negative tests, and they're putting them on these vents, hopeful that they'll get it. They're being put on these COVID floors. Is murder. It straight up is. It is setting these people up for failure based on money.
But Medicaid is who pays out, or who's paying this bonus of $29,000?
I believe it's Medicaid, Medicare. It's government money, but I don't know exactly where it's coming from. But I know that it is. But I know the orders are coming from the above, someone above, and everybody says that it's someone higher up. I'm like, good, call them. Like during that DNR when they're telling us, or the full code when they're telling us not to, do CPR. I'm like, all right, call your higher ups then. Let's talk about. And they wouldn't, because they're all scared. Everybody's scared, and everybody's scared to stick up for themselves. And I've called a lot of doctors unethical to their face, and they deserve it.
I am a nurse. I'm an advocate for my patients, and
to the flip side of it, but I totally agree.
But no. Just wait.
If there's a DNR.
You were laughing and you thought it was funny. You were like smirking. You're being really rude to all of us, and I thought that was really.
I'm not being rude in that.
It was really, yeah, you are. It was very disrespectful, okay. And I don't think that you're going to be a very good doctor.
Okay, I understand. Thank you.
You're welcome. I hope you learned something from this.
Was this the dentist, or or these are residents you're talking to?
This one was a fellow. She was a CCU fellow. Cardiac. She's a cardiac fellow.
What killed him? Did the vent kill him?
Yeah. Oh, yes. They're so sedated. He had probably 8 or 9 drips. It's all sedation. It's all sedation and paralytics. So you are asleep. It is essentially like you're under, you're in surgery, when they put you under like that, for a good month straight. There's no way you can recover from something like that. You'll be brain dead if you do.
So can you list some of the drugs that they're put on the drips?
Yeah, there's propofol, fentanyl, Nimbex, Versed. Gosh, hang on, I have a list. I think it lists from. This is one of my patients was on this. Just one patient. So Nimbex 100 milligrams, Precedex 400 milligrams, fentanyl 2,500 micrograms, heparin 25,000 units, Versed 50 milligrams, Levophed 16,000, Neo 50 milligrams, Propofol 10 milligrams, Vasopressin 100 units. This is one person, and all these drips are running at the same time into them.
So, in the case of this 37-year-old, he comes in complaining of some respiratory distress. Did he have low blood oxygen?
Totally healthy guy, and he was satting that's the oxygen saturations, and 88, 89.
So a little low.
I mean, yeah, but people do that. You and I probably do that. We're not monitoring our oxygen, all day long.
But he felt shortness of breath, so he came in.
Yes.
And what was the next step? What would have happened next?
He went to a step-down unit, among other.
What does that mean? Sorry.
It's just a unit where people aren't quite on the vent yet, and I say on the vent yet because I should call it a step-up unit to the vent. But
so was he? What's the phrase you used?
COVID rule out.
COVID rule out.
So that's how they admit everyone to the floor that doesn't have a positive COVID immediately.
Okay, so he's put in the step-down unit, which is a euphemism for step-up unit.
Yeah. And
what happens to him there? What's going on there?
Oxygen. I wasn't in this unit. My friend was.
So just normal oxygen, nasal?
No, they'll do a high pressure.
So what does that mean exactly? What does it look like?
Pretty much like a forced. It almost looks like a big thick nasal cannula, and you put it in your nose and it forces the pressure in. It can almost be it's still causing your lungs to expand, right? But what they really need to be doing is the non-rebreather mask, but they just skip it usually. They go right to the high pressure, so their lungs are already,
So, and tell us what a non-rebreather mask is?
So that's just, there's a bag that is on the end of these masks. It's not forcing air down your lungs.
Okay.
It's more natural.
Okay.
You know, and you can put 100% oxygen. That's what people need.
That okay. So and that really is not the protocol. It's not the protocol to start people on that.
I mean, it should be, but it's not how they're doing it now.
I mean, in your prior experience dealing with people with low saturation, would that be what you would do?
Oh yeah, that's what we were doing, you know, in my hometown.
And were you having better outcomes there?
Yeah, we didn't have this because we treated them properly, you know.
What would you say the kind of the case fatality rate was?
None. 0. Yeah, by me, 0.
And what is the likelihood of coming out of the hospital you're in?
I'll tell you that the unit that I've been on, the only person that survived, ironically, is a guy who pulled his own tube out. Yeah.
So he woke up enough to be able to do that?
Yeah. He wanted it out. He should have never been on in the first place. That's a whole nother story.
So let's just keep going with this
Yeah.
37-year-old. So he's on the step-down unit, and he's being given sort of semi-pressurized oxygen. It's not a rebreather mask. And then what happens to him?
They'll start treating them with medications, you know, that will...
And are they checking his saturation at this all the time? Does he have...
Yeah, he's on a continuous pulse ox, but, you know, the minute that he desats, like, they'll see, like, oh, no, he's at 87 now. Or, oh, look at this. Oh, he's going to need more help. And then they go tell them that they need more help, even if they don't. You know, it's ultimately what it comes down to is, like, people being just lazy and wanting to treat. They just want to treat. You know.
Is there any incentive to the... Okay, you're saying that the incentive for the residents is kind of experimental almost.
They're order followers.
And they're...
You know, like, they want to please. That's what they're doing. They want to please. And, like, the protocol of that hospital is to treat.
To treat invasively according to this protocol. And do we know where this protocol originates? I mean, because obviously the governor was talking about getting vents. Everyone was talking about getting vents. So this seems like this comes from very high up.
Yeah, I mean, if you're gonna tell somebody, the entire world essentially, especially the entire United States, when they're like, we need the vents, like, if you tell people something enough, they're going to start believing it. So that's exactly what happened.
Tell me why Cuomo immediately thought 2 months ago that they'd need 30,000 vents. How do you just come up with a number?
Cuomo's an idiot too.
Well, Medicaid's paying them more money for people.
29,000 a vent.
So our 37-year-old, what happens to him next? So they say, okay, it looks like he's at 87, he needs more, and so is that the point at which they would intubate him?
Yeah, that's when he that's when he stepped up. So he stepped up to the ICU.
He steps up to the ICU.
For more care, right? They start off with a little bit of, like, muscle relaxer, and you know, he's woozy. You have to remember there's no family with these patients, so they're alone and in hospital by themselves during a pandemic that they're terrified of already. That's likely what brought him in the first place. He's totally healthy otherwise. And then you have doctors. They think they're doctors, but they're resident. Technically, they're doctors with absolutely zero experience. I've had to teach residents several, like, nursing skills. Telling them that they have a choice, you know, like, they could likely die from this, or they can be saved by, you know, getting a tube, and that will help them breathe. They don't call it ventilator. We can give you a little help breathing, and that's it. Then they get the sedation, and they go to sleep, and that's it. They don't wake up. He's in a body bag.
And so the drugs have a deleterious effect on the body, on the brain, but is there something about the pressurization of the lungs that is also causing harm?
Yeah, they're having the PEEP, that's the pressure in his lungs, which is causing the barotrauma of people. It's blowing people's lungs out. So when that happens, what do you got to do? Turn it up more. You just keep.
Because the membrane expands, so that you need, in order to fill them and deflate them, you need more pressure.
Yeah, you're gonna have to max it. I mean, we have a guy right now who's maxed out on everything. There's nothing more you can do. So then what? You just wait for them to die? I mean, there's nothing you can do.
Can you tell us what PEEP levels are they started on?
It depends. They're always usually, well, they'll start, there's some good ones. I can't say everybody's bad.
Mm-hmm.
There are some good doctors that'll start them out on 5, which people should be at about 5. But that doctor goes home and the next doctor comes on shift and cranks it up. Then what? It's hard to go back down.
And what oxygen level are they put on?
It depends. I mean, as they start to deteriorate more and more, then the oxygen obviously is going up. There's a guy right now, I have him on 100%, and I'll have to come in and, give him a little bit more rush of 2 minutes of even more oxygen just to keep his stats up. I mean, that's what happens to people.
In your home state where you were treating people, what would the protocol be?
I mean, it varied upon each individual, but we definitely would never go immediately to, you're going to need a vent.
You didn't feel pressure to diagnose people? There wasn't a pressure to diagnose people COVID?
Not at all. No. We're not a public hospital, too. That makes a huge difference. What I'm seeing is it's the public hospitals, and this is like in other states, too. If you look at all the hospitals, most of them are public that are needing money. But our hospital would just treat them based on the individuals, and they were using the hydroxychloroquine and the zinc and, that protocol for sure.
At your hospital?
Oh, yeah.
And that seemed to work?
Yeah. We didn't have anybody that died. I think there was one patient that was admitted and went home like the day later. And I'm in a pretty big city, so.
And were these people who were elderly with comorbidities who were having good outcomes?
Yeah, actually one guy the one guy that was admitted came from a nursing home. And he was obese, like severely obese.
And he
yeah,
left.
He's fine.
He left after a day?
I think it was like a night, maybe 2 nights max, but.
And what do you remember what he was treated with?
I didn't have him on the floor, but I can imagine he was treated with the protocol that we would prescribe the patients before they left the emergency room.
Which was?
With the hydroxychloroquine, zinc.
Why do you think that's been demonized so much?
Because it's working, and then people wouldn't need vents. I don't know.
Only on 2 tonight, a Houston hospital is having success treating the coronavirus patients. In fact, its recovery rate is perfect.
Fascinating, isn't it? To treat patients here, Dr. Veron is using an experimental drug protocol. It's a cocktail of vitamins, steroids, and blood thinners. Each patient also is getting hydroxychloroquine, the malaria drug touted by President Trump. The protocol is controversial because there hasn't been time for extensive testing, but Dr. Veron says it works.
We've treated over 40 plus patients with this treatment, and we haven't had a single complication.
So far, he says, none of his patients have died.
This is time of war. There is no time to double blind anything. This is working. And if it's working, I'm going to keep on doing it.
What we're finding clinically with our patients is that it really only works in conjunction with zinc. So the hydroxychloroquine opens the zinc channel, zinc goes into the cell, it then blocks the replication of the cellular machinery.
You're prescribing it, and it is working for COVID-19 patients.
Every patient I prescribed it to has been very, very ill, and within 8 to 12 hours, they were basically symptom-free. And so clinically, I am seeing a resolution. That mirrors what we saw in the French study and some of the other studies worldwide. But what I am seeing is that people are taking it alone by itself, it's not having efficacy.
Okay.
What can you tell us about any confirmed COVID cases that you've seen? both in your home state and here in New York. What have you noticed about them, and what do their stats look like?
Okay, so the real confirmed COVIDs that come in, like, you immediately know that they're COVID because they cannot, they can't breathe. They literally can't breathe. So they do need that non-rebreather mask, or their stats will quickly drop to 60s, 70s. You want to be at around 90 to 100.
So they can't talk even.
Some of them can talk. A lot of this is anxiety, but the problem with this is they were being told, the public has been told to self-quarantine, right? Stay home. That's a problem because these people could be getting early treatment.
There's clinical trials emerging that appears to show that it decreases severity early in the game, before you end up hospitalized, before you end up on a ventilator.
And they're not, because they were told to stay home. So now they're getting really, really sick, and they come in on an emergency status. They waited too long. If they didn't wait too long, they're easily treatable.
And easily treatable, you feel, with some of these treatments,
yeah,
like
100%.
Zinc and hydroxychloroquine, and
it's working. I mean, it's been proven to work. There's a doctor, I think, in Texas that's using that protocol and a shot in the butt, of antibiotic shot. I don't know exactly which one she was using, and she's successfully treating. And she was saying that the pharmacist now is calling her every time that she prescribes, the hydroxychloroquine, and asking what the diagnosis was of the patients in order to give it to them. I'm like, that's a doctor-patient relationship. So the pharmacist, I guess, was told to do this. And, in New York, the governor said, pretty much put a ban on it. So why? What made him, a medical professional now to make these decisions and intrude on the doctor-patient relationship? I think I know. I've seen it. They want a vent. He wants to be right. They requested all these vents. They want to use them.
As part of the same executive order that granted hospitals near blanket immunity from malpractice litigation during the epidemic, Governor Cuomo singled out hydroxychloroquine as the one drug that could not be used as an off-label therapy for COVID-19. Except as a part of approved studies. The order was issued ostensibly to prevent hoarding, so that those who take this decades-old, inexpensive treatment with a long safety record for approved conditions like lupus would have access to it. He later amended the order to allow hydroxychloroquine's use in later-stage patients in hospitals, but not in early outpatient treatment. Both hydroxychloroquine and chloroquine had shown efficacy in the prior SARS coronavirus epidemic, and studies in France and other countries had already shown its effectiveness for COVID-19. But instead of making research and production of a promising therapy a priority so that there wouldn't be shortages, vents became the near-exclusive focus, along with the search for a vaccine. This has been true even of President Trump, who, despite his public cheering for hydroxychloroquine, has not made it the focus of warp speed funding and testing. A number of U.S. studies have shown the promise of hydroxychloroquine-based therapies, most recently a Yale University study focused on early treatment. And in what may be the most scandalous retraction in recent memory, a Lancet paper that purported to show hydroxychloroquine alone or with other therapies was in fact dangerous has been shown to be based on fraudulent data. Aaron's home hospital system confirmed in a phone conversation with Perspectives on the Pandemic that they have used a protocol involving hydroxychloroquine and zinc to great effect.
Because in your view, this should be an individually decided doctor-patient choice.
Everything should be that. I mean, there is no reason that any government should get in between a doctor-patient relationship. That's none of their business.